So we've talked about life stressors and unexpressed grief. Someone dies who you're very close to, and you don't process the emotion. Later, it comes out in a physical form. We talked about
And
learning theory. Go ahead.
right. And I was going to say, and it seems as though to some extent it's realistic. If you have a family history of cardiac disease, it makes sense to go get checked out. But I guess when does it become
That's a great
unrealistic
point. There's healthy
to,
monitoring and unhealthy monitoring, and it could be
right.
totally bad if you're denying the fact that you have this genetic history of heart disease, and you don't worry at all. That could be bad as well.
So when does it cross the line into sort of pathological behavior?
That's a very good question, and it's a very tough one to answer. I mean, in a crude sort of way, I think what we say is a second opinion is great. A 10th opinion probably doesn't make much sense. That it's, you need to trust your physician. You need to really believe that the doctor's competent and has taken you seriously. And there's nothing wrong with assuring yourself of that. But at some point, it becomes it makes a lot of sense to step back and say, you know, it's unlikely if I've seen 3 or 4 or 5 gastroenterologists, it's really unlikely that the sixth one is going to have a different opinion. And so it's very difficult to know quite where to draw that line. And as Brian said, it is absolutely crucial that when something's worrisome, you get it checked out. But you also need to use some reasonable sense of when enough is enough. And that's part of the trick, I think, in dealing with successfully with hypochondriasis is to begin to turn some of your energies away from that quest for the diagnosis, for the miraculous answer, for the
Right.
definitive cure, and use some of that time and energy and effort and expense in learning to cope with it, in learning to minimize your worries, and to compensate for them, to minimize the symptoms, to overcome them. And in our experience, I think, and I think all of us have found in treating people with hypochondriasis, the people who do the best are the ones who accept the fact that they are stuck with some kind of problem that no one really can explain very adequately and turn their efforts to making the best of it.
Mm.
Certainly would be great if everybody could do it, but you found in your studies actually with cognitive behavioral therapy that you have a very good responder rate. What have your prior studies shown?
Well, we've done essentially that sort of treatment, and basically more than half of the patients are better, clinically significantly better 6 months and 12
So you
months
can help
after
change
treatment.
that, which is great.
And you know, it's by no means a cure for everyone, and it's often a difficult problem, as we've been saying. That's very tenacious. These concerns, they stick around. They've been there for a long time, often, and so it's not realistic to expect that they're just going to completely go away after 6 sessions of cognitive behavior therapy. But for a majority of patients, there significant gains are made.
Yeah. I'd like to talk about one other cause of hypochondriasis, which is I think some people actually inherit an obsessional style. And when I listen to a hypochondriac talk, sometimes they say, "But doc, how can I be sure that I don't have cancer? How can I be absolutely confident that that symptom that I have isn't something, a sign of something serious?" And I say, "Well, you've been to the doctor, you've been evaluated." "Yeah, but how do I know that person has done the tests?" Or what if the doctor was distracted and thinking about something else? And those questions, the what if questions, how do I know questions, those to me are signs of something called the pathology of doubt, which is an inability to be comfortable with a certain level of uncertainty. And people with the pathology of doubt, of being unsure, ask what if questions or how do I know questions. And those are the people who have an obsessional disorder. And whenever I hear that, I'm delighted because I know that those patients can get a lot better with the treatments that we offer. But I actually think that's a genetically inherited trait, so it's not like they had any major trauma necessarily, uh, or that they're purposely doing anything. It's just that this is a style of thinking and emotional processing that they've developed and probably others in their family have, which is either manifest as sometimes worrying too much and they have generalized anxiety disorder, maybe other family members, or other family members, somebody might have anorexia or body dysmorphic disorder where they worry too much about their facial appearance. So sometimes you see an overlap in the obsessional disorders. Now, Arthur, you've talked a lot in the past about somatic amplification, And I wondered if you think that might be something that's genetically inherited, the tendency to focus too much on your bodily symptoms.
Oh, yeah, I was
Go
just
ahead.
thinking the
Yeah.
same thing because it's true. It seems as like exactly what you were saying that some people seem to inherit this more obsessional, scanning their body. They're more aware of their body. Other people seem completely unaware, and you often see it in relation to pain. But we're
Yeah,
curious to hear your
absolutely.
thoughts on
I
that.
think there's that range, just the way some people have much better vision than other people, and some people have better hearing than other people. Some people are just much more aware of what's going on inside their bodies, and they can pick up and notice all kinds of stuff that most of us either don't notice at all, or we do, but we ignore it.
Mm.
Gurgling in your stomach and your heart pounding when just normally at rest. You can hear your pulse in your ear at night on the pillow when you're trying to go to sleep. I mean, there are lots of examples like that of sort of normal bodily processes, and some people are just very sensitive to that stuff. And we do think that that often can predispose people to being hypochondriacal.
And it's interesting because I think in the treatment you were talking about, it sounds like you try to channel some of that into then helping people learn to live with their symptoms a little bit better.
Yeah, exactly. That's really the strategy, is to begin to realize that what's really going on is the way in which they're processing sensory information. I mean, what we tell people is that you've got a software problem, not a hardware problem, that there's not something wrong physically somewhere in your body. It's the way in which you experience it, the way you're processing sensory information that's really causing the trouble.
And that the treatments that we have actually can fix the software.
That's right.
Well, with that, I will go ahead and conclude. But again, if you want to find out more, certainly check out our websites. For the Boston site, it is thehealthstudy.com. And for the New York site, it is illnessworry.cumc.columbia.edu.
And may I add something
Sure.
at the very end here? Just that I think that since we have with us people who know a lot about hypochondriasis, maybe we'll just have one segment where we give advice to the hypochondriac about what you should do to get better. A good approach to trying to get better. So look out for that segment.
All right. Sounds good.